And then I'm really excited to introduce our first speaker. So Dr. Blake Beehler is our second year Movement Disorders Fellow, or one of them, and he did his residency at Rush University. And he's going to talk with us today about medical management for Parkinson's disease. So thank you, Dr. Beehler.
All right. Hello, everyone. Welcome. I'm happy to be the first speaker today and kind of have an important topic. It was kind of hard to distill into a bite-sized talk here. So I'll be going relatively quickly and just kind of reviewing a lot of the mainstay treatments that we use for Parkinson's disease and going over some of the more recent advances, because thankfully for Parkinson's disease, we're always moving forward and research is pushing us to further heights. And I'll kind of describe some of the newer medications that have been approved in the past year. Like Dr. Marr said, I'm the second year Movement Disorders Fellow here at the University of Colorado, and I have no financial disclosures to display. This is just a talk about kind of the facts of the medications and not influenced by any external factors. These are the goals and objectives of the talk. So I'll briefly introduce us to Parkinson's disease since I'm the first talk. I'll describe how levodopa formulations work, which is one of the mainstay treatments of Parkinson's disease, and I'll discuss some of the recently approved medications. So just very briefly, Parkinson's disease was first described by James Parkinson, where the name came from, in 1817 when he published an essay on a series of patients with similar presentations. And it wasn't until the 1960s that we actually discovered that dopamine, a neurotransmitter in the brain, was actually reduced in Parkinson's disease, and that levodopa, which is a precursor to dopamine, or a chemical very similar to dopamine that can be converted to dopamine easily in the body, when we give that to patients with Parkinson's disease, it can actually improve many of the cardinal features of the disease. So Parkinson's disease briefly is a loss of brain cells in the certain area of the brain that produce dopamine. And dopamine, like I said, is a neurotransmitter, which is just a chemical that allows the cells of the brain, or the neurons, to communicate and send signals to each other. And that loss of dopamine producing cells in Parkinson's disease is responsible for what we call the cardinal features or main features of the disease, which is the resting tremor, the rigidity or stiffness, and the bradykinesia, which just means slowness of movements. And we found that the loss of the dopamine leads to those symptoms, and the giving dopamine back tends to alleviate those symptoms as well. So this is a busy slide. I'm not going to go over the entire thing, but this is just to show you that there's many different medication classes that we use when we think about developing treatment plans for patients with Parkinson's disease. It's a very personalized approach with you and your doctor. It centers a large amount around the dopamine system in the brain, including the levodopa replacement, which involves dopamine, but there's other neurochemical and neurotransmitters that we can manipulate and use medications to help alleviate some of the other symptoms of Parkinson's disease. For the sake of time in this talk, I do want to primarily focus on the levodopa replacement therapy, as that's been where some of the more recent advances have been, and is a good basis for understanding the medication management. But again, talking with your doctor, there may be a role for having a couple different medications to work synergistically to help improve symptoms. So getting into the levodopa, so it's the mainstay treatment for Parkinson's disease. We've been using it since the 1960s. The brand name that we typically use is Sinemet, which interestingly, if you take it apart, just the sin just means without, and the emet just means emesis. So it was designed to have the carbidopa as well as the levodopa. So they're two distinct medications. And the carbidopa helps reduce some of those side effects from the levodopa itself, mainly nausea or vomiting. So that's what they came up with the name. We commonly use levodopa, carbidopa, levodopa, and Sinemet relatively interchangeably. And levodopa, like I mentioned, is a precursor to dopamine. It means it's a chemical that's very similar to dopamine. And then when you give it to the body, it's able to actually convert it into dopamine and then use it for the normal processing it needs to in the brain. And this is the only scientific picture I want to include on the slide, but I just think it's really interesting to take a look at the chemical structure of dopamine versus levodopa. They're essentially identical, except in that top corner of the levodopa, you see the COOH, which is what we call a carboxyl group. And that makes all the difference because it allows the levodopa to actually pass through the blood-brain barrier, which is that very tight junction that regulates what actually gets into the brain from the blood. And it allows the levodopa to go into the brain, where it's then converted to dopamine by the natural enzymes in the brain and can then be used as dopamine. So they're very similar in composition. And it's just to overcome that blood-brain barrier to get it into the brain where it needs to be. And then the carbidopa, like I said, was added to prevent some of the side effects. So when dopamine is present in the bloodstream, it can cause some of the common side effects that we see with dopamine therapy, including the nausea and the vomiting. So the carbidopa actually just blocks that conversion of the dopamine in the bloodstream so that it can get up into the brain, get into the brain, and then be converted to dopamine where we want it to, rather than being converted to dopamine in where we don't want it to and causing side effects. So the main side effects are the GI upset and nausea and vomiting. This is tempered by the carbidopa, but still we hear patients can still have issues with this. It can also cause some dizziness, lightheadedness, which is closely tied to some drops in blood pressure. And it can contribute to hallucinations generally seen in more advanced stages of Parkinson's disease, when hallucinations may already be present, but it may sort of potentially contribute to those. And at that point, we may talk about maybe reducing the medications if the hallucinations are bothersome. And then importantly, it's good to be knowledgeable of what dyskinesias are. So they're sort of extra wiggly movements, and they can result from levodopa therapy. A typical example I use is Michael J. Fox, and I've got a video that I'll play here that just shows him at a press conference. I can't turn the sound off, I'm sorry. But you'll notice that he just has a lot of extra movements. He's a little bit more kind of wiggly. He's got some head movements, mouth movements. Those would be the and he's just not able to stay as still. They're not bad in themselves, but this is just what dyskinesias look like. It is a result of the duration of Parkinson's disease. So Michael J. Fox has had it for decades at this point. And it's also a contribution of the total dose amount of the dopamine replacement therapy. So that's just an example of the movements, just to be knowledgeable of. I'd also like to take a second to debunk some myths that we hear from levodopa. Levodopa is not toxic. It does not hasten disease progression. Levodopa does not lose its efficacy over time. There are changes that occur naturally in the disease progression, as it is a neurodegenerative disease and it can change over time. But the levodopa is not the thing that's responsible for it. And levodopa does not lead to earlier dyskinesias. We hear this one a lot because it used to be, we thought that it led to earlier onset of the dyskinesias, maybe 10, 15 years ago, but there's been plenty of studies since that time that have determined that start delaying the onset of using levodopa therapy does not delay the onset of dyskinesias. It is purely a contribution of how long the disease process has been occurring and the total dose of the levodopa. So as it's a very good treatment for Parkinson's disease and can really control symptoms very well, there's not really too much of a point in delaying giving people one of the most effective medications that we have for the disease. So typically in our center and many academic centers in the country, levodopa is one of the first medications that we go to when patients are presenting with early signs of Parkinson's disease. This is just a graphic representation of some of the progression that we can see in Parkinson's disease, and I'll try to break it down for you a little bit. So on the left-hand side of the screen, you can see that when we take medication, the blood levels of the levodopa can go up. If the blood levels are too high, we may run into some of those dyskinesias, the extra movements. And when the levels of the medication are too low, we get what we call off periods or wearing off. And what we mean by off periods versus on periods is the off periods are when the Parkinson's symptoms are a little bit more bothersome. So that'd be the slowness, the stiffness, the rigidity. And the on periods are when the medication's working well. You feel like the symptoms are well controlled and you're able to do things more easily. And so using that terminology helps us in designing some of the medication regimens for patients, and being knowledgeable about that is good to know. And then this is also a nice representation that of as the disease progresses, as opposed to the medication causing issues, the underlying disease process is still progressing, unfortunately. And we may have a little bit more trouble staying within that good on time where we're not having dyskinesias and their symptoms are well treated. So we may be needing to shorten the time between doses to try to reduce some of that wearing off. We may be needing to reduce the individual doses and spreading them out more to try to avoid some of those dyskinesias. And there's many things that we can do as far as treatment plans to try to minimize some of the difficulties that we see as the disease progresses, mainly trying to identify and improve the amount of time in that good on time or the therapeutic window that we see in the center there. All right, so talking a little bit more about levodopa. This has been a mainstay in treatment for decades and has been a site of a lot of innovation to try to improve the medication. So typically, the oldest medication and cheapest medication is the Sinemet or immediate release carbidopa-levodopa. It has a quick peak of the dose. And then typically when we start patients, it's usually dosed 3 times a day, which can be kind of cumbersome for people who are not used to taking medications. And we may need to shorten that time duration as the disease progresses and taking it more frequently during the day. Because of that and the frequency of medication, that's where a lot of innovation has occurred to try to extend that duration of the medication, to try to lessen the amount that people need to take per day. And so we also have the controlled release or extended release formulation, which is a slightly slower onset and a slightly lower peak, but realistically doesn't last too much longer than the Sinemet immediate release. Sometimes we use this in the evening to potentially extend some symptom benefit over sleep. The other formulation that people are likely familiar with is called Rytary. It's a combination of the immediate release and the extended release. It has an initial peak of the immediate release, and then the extended release ideally slowly releases in the area of the gut where it needs to be absorbed and extends that duration of treatment. So typically we can maybe expand the amount of times between doses during the day. And then I'll briefly talk about it here, but we'll go into a little bit more in depth. The newer medication is, again, the same formulation of carbidopa-levodopa. I'll stress this, all of these medications are carbidopa-levodopa. It's just a change in the delivery system to try to extend the duration of how long it's working. And the new medication, Crexont, is again carbidopa-levodopa. It has immediate release granules and extended release pellets. And their large innovation that they claim with this new medication is that the extended release pellets have a mucoadhesive polymer, which is a fancy word just to say that there's a coating that allows it to help stick to the gut. And ideally, it's sticking to the small intestine where we typically absorb the most levodopa, and then it kind of slowly releases the medication over time. So they're using kind of a new delivery system of the same medication to try to prolong those effects and lessen the amount of times we need to take the medication during the day. So Crexont is the brand name for the new carbidopa-levodopa. It was approved in August of 2024. The original trial showed improvement in the daily on time compared to the immediate release formulation. So they compared head to head with immediate release. They didn't look at kind of its effect compared to Rytary. And comparing the immediate release group who were taking medication 5 times a day, the Crexont was able to be dosed 3 times a day with still improvement in that on time. I just want to briefly mention there's another formulation of carbidopa-levodopa. Like I said, all of this medication is kind of the same medication. It's just different delivery systems. For patients who are pretty sensitive to small dose adjustments, there is a medication called Divi. It's brand name only, unfortunately, so it can be a little bit more expensive. And the only difference is that it has quarter scoring. Sometimes we have patients cut the carbidopa-levodopa immediate release in half to give a half dose or a smaller dose. The Divi just allows even quarter dosing for even smaller adjustments. And I just want to make sure that people are aware of that in case that they are a little bit sensitive. They could talk to their doctor about maybe seeing if this is available and affordable for them. I also want to spend a little bit of time talking about the new subcutaneous pumps, as this is a new delivery system that's come out for Parkinson's disease. And in the past year, we've seen a couple of medications that have been approved. The idea behind it is that we're delivering medication underneath the skin. So that's subcutaneous just means underneath the skin. Which can lead to some site reactions or skin reactions, including redness, irritation, and skin infections. But the goal behind this treatment is to avoid that kind of peaks and valleys of the oral absorption. So it's a steady delivery system of delivering the drug underneath the skin. You don't need to wait for it to go through the digestive system to get absorbed. And it's just absorbed through the bloodstream from where it's delivered underneath the skin. It's kind of similar to what's been available in diabetes with insulin pumps. There are 2 devices that have recently completed FDA approval, one from Supernus and one from AbbVie. They are Anapco and Vyalev respectively. And then there's an additional device that is pending FDA approval. Likely, I imagine we'll receive it in the next 1 to 2 years, and that's another formulation of the carbidopa-levodopa. So the new pump from AbbVie is called Vyalev. It's a phoscarbidopa, phoslevodopa. So again, it's that same medication that's been the mainstay of treatment for years. The FOS just means it's a way that they're able to keep it in liquid form. And it works by keeping dopamine levels a little bit more consistent, trying to reduce those peaks and valleys of the oral absorption as medicine kicks in or wears off. And it's used 24 hours a day. That's a picture of the device. So it's about the size of maybe two cell phones stacked up to each other, and it connects to a small cannula, which inserts into the skin. In their original trial, they compared to oral Cinemet, and this device actually replaced the previous carbidopa-levodopa usage as it's delivering it in another way. And so people weren't needing to take the oral pills. And compared to oral Cinemet, it added an additional hour and 45 minutes of additional good on time during the day on average, and then an additional or lessened the off time where those symptoms are more bothersome, lessened it by about an hour and 50 minutes. So a little bit more steady compared to the immediate release. They didn't compare it to either of the other extended release formulations of carbidopa-levodopa. This pump allows for a little bit of adjustable dosing. It's set up by your doctor, and they can set either high or low rates and the base rate, depending on kind of activity levels or things that you're doing. And then there's also an extra dose button to take as needed. You can also take oral Cinemet while on this, but it replaces primarily most of the carbidopa-levodopa that people are taking. It is easily removable for up to an hour. You just detach that little plastic tubing, and you're able to shower or swim or do an exercise or recharge the battery. And something to note that I mentioned in the first slide, with these subcutaneous pumps, it's relatively common to see skin reactions. So in this trial, about 72% of patients in the original study had skin changes, which could either be nodules, which are small bumps underneath the skin. There could be redness, there could be pain, swelling, skin infection, and bruising. Typically, we recommend rotating the site of the cannula every few days to try to minimize this, and most of these resolve on their own, but just if you're considering something like this, it is relatively common that skin reactions are going to occur. The other new device is a different formulation. It's actually apomorphine, which is called a dopamine agonist, which just means it's a lookalike like dopamine. And it's delivered also as a constant rate underneath the skin, trying to reduce those peaks and valleys of the oral formulations. And this one is not typically used during sleep. It's usually just during the waking hours. It also does not completely replace oral therapies. But 33% of people in their original study discontinued at least one of their Parkinson's medications by week 4. And 15%, and on average, people would reduce the amount of levodopa they were taking 15%. Compared to the control arm, which was a placebo, which is just as a water infusion, they had an hour and 42 minutes of an additional good on time and 2.5 hours less off time during the day. And you'll notice that these numbers are different from the Vyalev, but you have to take into account that the patient populations they were looking at were different. So the apomorphine group tended to have a little bit more off time to start, so that's why there was a little bit more improvement in the off time. The other difference is that with the apomorphine pump, people remained on their oral treatments. They just needed to be titrated down on those medications, and this was kind of an adjunct to their current treatment, as opposed to the Vyalev, which replaced most of the oral carbidopa-levodopa. The rate is adjusted by your doctor with ability to give an extra dose as needed. And again, similarly to Vyalev, you see that there's a pretty high incidence of skin reactions, either being nodules, redness, pain, swelling, or bruising. Typically, these resolve on their own, but it's something to be knowledgeable of. When talking about these new therapies, I do want to make a caveat that they're currently not approved by Medicare, which is a large insurance that we see in our patient populations. Hopefully that they will make a decision on that soon, but currently when talking to the device companies, the out-of-pocket cost for these devices are over $100,000 a year, which makes it fairly difficult to get our patients enrolled in this, but hopefully as the Medicare update their coverage of these newer devices, we can bring that down for patients to make it a little bit more affordable. Another important aspect is continued research. So there are always kind of advances in Parkinson's disease. I couldn't touch on every medication today, but there's additional medications in the pipeline to be aware of. There's another device that should be eventually approved in the next 1 to 2 years called Neuroderm, which is another subcutaneous delivery device of carbidopa-levodopa. There's also a medication which doesn't have a name yet called P2B001, which is another recombination of 2 current medications called pramipexole and rasagiline. And then there's another medication called tavapadon, which is a little bit more selective in which dopamine receptors in the brain it's targeting, and ideally is minimizing some of the side effects that we see with some of the medications. So there's always new things coming down the pipeline. And I appreciate your attention.